Okay, thank you so much for the introduction to our topic. I present individualized growth trajectories for preterm infants, association with short and long-term outcomes. We have a huge study group. It was a multi-center international study. Growth can be divided in different periods. We have the time of intrauterine growth, then there's a postnatal adaptation, and then there is a period of stable growth of preterm infants, here shown at 3, and then the transition to the normal term growth. During postnatal adaptation, all newborns usually lose weight, and one part of this portion is nutritional deficiency, in particular in preterm infants, when the nutrition is not fully established during the first week of life. But the main portion of the weight loss is just water due to constriction of extracellular body spaces and the loss of fluid. However, it is unclear how a preterm baby should grow during the hospital stay. Whether the preterm infant should have a very fast growth rate, or should the infant grow here on the lower trajectory. There is a lot of knowledge gap. If we look into term infants, and here shown as a 50th percentile, then we see how this term infant growth in utero, and then the term infant is born, has a postnatal weight loss, and then follows the WHO curves here, for example, also along the 50th percentile. Preterm infants have also postnatal weight loss, shown here. But then it remains unclear how the preterm infant should grow. If we, for example, follow this upper trajectory, then infants maybe end up with a higher body fat. However, the lean mass is also improving. If an infant would follow a lower trajectory, then the fat mass would be maybe reduced, but also the lean mass would be reduced in those infants. However, it is suggested that preterm infants should mimic intrauterine growth rates. They should have a body composition as well as a functional outcome comparable to term infants. And here on the left side you see a kind of hypothetical thinking. We have a twin pregnancy with 2 identical twins. The one twin, the preterm twin, is born as a preterm infant. However, the other one stays in utero. And if we now follow the curve of the preterm infant, then there is a weight loss during the preterm birth, and then the infant is following this postnatal trajectory, whereas the other one stays in utero, has also weight loss, and then it would be plausible that both merge together with their growth trajectories in the post-term period. However, it is unclear how infants should grow preterm infants should grow during the NICU stay, and we found that the best estimation is using the growth rate of the 50th percentile in order to mimic the growth rate after the postnatal weight loss, but this needed also some correction for the postnatal environment due to the water loss. This concept is we have developed a concept of individualized growth trajectory, which is based on 4 physiological concepts. The first concept is that during the period in utero, we follow the fetal growth using the Fenton growth charts, analyzing with these growth charts the birth weight percentile. Then the second concept is the postnatal adaptation. Here we used healthy preterm infants. 1,000 infants were analyzed in this study, and we developed a model how preterm infant will adjust during the first weeks of life. Then we following, after this postnatal adaptation, the median daily growth rates from the Fenton curve. So we take the 50th percentile and adjust the growth rate for the postnatal extrauterine environment. And then in the post-term period, the growth trajectory of preterm infants merge with the WHO curves. In the study, the objective was to compare the observed deviation of the weight gain, here shown as delta W, from the GTC trajectory between cohorts, and to analyze relationships between delta W and short-term outcomes. This was a multi-center study done with centers in North America, Europe, and Australia. Included in the study were infants with 22 to 33 weeks of gestation. In this part of the study, we mainly focused on short-term outcomes like body composition, blood pressure, head circumference length. Here you see an overview. The slide is very busy, but I only would like to mention that the mean gestational age was similar between the cohorts, and also the birth weight was in a similar range. So we compared similar infants from different units. What you see here is an overview about the deviation from the target weight for infants born at different gestational age, 22 to 23, then increasing gestational age up to 32 weeks here. What we see that infants with more immature gestational age were not, or were more below the target trajectory. Here shown, the full line is the median deviation for postmenstrual age, shown in the x-axis. However, infants with a later gestational age were able to achieve the growth trajectories. Then we were looking into difference between centers, and we found a huge variation and huge center difference in terms of the deviation from the target weight. There were centers which achieved, even for the 22, 23 weekers, the growth trajectory, here shown in the red line. However, there were other centers which had different growth trajectories. And differences in this group were up to 680 gram. With increasing gestational age, the differences between centers became smaller. When we analyzed the relationship between the body composition and the deviation from the growth trajectory, then we saw that infants which were above or had a less deviation from the growth trajectory had a positive correlation with percent fat mass, and also lean mass. This slide looks also a little bit busy. We have here divided infants in quartiles for their deviation at 4 weeks of life and 10 weeks of life. And then we looked in this Sankey diagram how the deviation from the target weight is changing during the hospital stay, and in which quartiles infants end up during this time. Then we analyzed the body composition and compared the data with the deviation from the target weight. We found that the initial phase during week 4 of life was not able to predict the body composition at discharge, here shown as percent fat mass. However, the deviation before discharge were closely correlated with the body composition. So infants which had a weight less than minus 180 gram below the target weight had a lower fat mass. Here you see infants which had not so much deviation, and minimizing the deviation shows that infants which were close to the trajectory had also here higher fat mass. However, infants which exceeded the growth trajectory had fat mass above 26%. Then we looked into the relationship of blood pressure and deviation from the target trajectory. What you see here are 2 cohorts. on the left in blue. These are infants which were far below the growth trajectory, the predicted growth trajectory, and we found there that infants with which were below the growth trajectory had higher blood pressures than those ones which were at the growth trajectory, and we see the opposite observation in infants which were far above the growth trajectory had also higher blood pressure. So that taking this, merging this data, combining this data shows a kind of U-shaped phenomena here. Then we compared how other measurements of growth would correlate, for example, with nutrition. Here you see data where we correlated the protein intake from infants with a deviation from the trajectory. We calculated then the correlation of weight gain, change in percentile during the intervention, and the change or the delta W comparing the individualized growth trajectories with individual weights. And then we correlated this with the nutrient intake, and here we found that the individualized growth trajectories best predicted or were best correlated with the protein intake. In summary, this is the first study to analyze the actual growth of preterm infants by comparing them to individualized growth trajectories. The results show that outcomes such as weight, body composition, and blood pressure were independently related to growth pattern. Thank you for your attention.